Hey guys, so I'm just gonna go ahead and get into it. If you guys need anything, let me know. In terms of just because I know I've been doing recordings, but I haven't had you guys do the form because I had a couple questions about that, which I that's super sweet that you guys want me to um get paid for this time. So I'll send that out in a couple of days. Just because I have like exams and I feel like I always have other things coming up. And as long as I do it by the end of the month, then I should be fine. Um, so let's see here. So we're going to talk about respiratory and cardiac. So I tried to review this information and I also am like recording this later in the day, but I wanted to just let you know like this stuff is a little bit rusty for me. I just tried to review it, but hopefully I'm able to help out with it. So it's nice that you guys are able to at least use me as another resource. So again, hopefully I'm able to explain the stuff that you have to know. And other than that, I just want to go ahead and get into it because I feel like this video might be a little long. Okay. So in terms of like the upper and lower airways for the ANP, I feel like you just have to be able to differentiate between those. That's not really asked, right? It's just you should probably know that. And I feel like we do, right? So all that stuff up there. In terms of your alveoli, they contain two different types of cells. So that helps with gas exchange. We have the type 1, which is your squamous, that just basically helps with rapid gas exchange from the blood and the alveoli. And then you have your second ones, which are your pneumocytes, which are in charge of basically secreting surfactant. And surfactant is basically what helps to keep the alveoli open. So that gas exchange can occur. And so in terms of oxygenation, we should remember that we're talking about ventilation and perfusion. I'll talk about that in a second. But one thing is that we want to make sure that the tissues are being oxygenated, and that's done through hemoglobin and plasma. So the CO2 is carried through the circulatory system to the lungs and it's removed from the blood as it diffuses into the alveoli and then is exhaled as a gas. So for the process of inspiration and expiration, so we definitely need to know this, and I feel like this makes sense when we start talking about chest tubes, right? So just remember for gas exchange, we're talking about going from a pressure of a positive place to a negative, right? So positive to negative pressure is what happens during breathing, and again, I'll explain it during chest tubes. For inspiration, again, this is when we're inhaling. So basically the diaphragm contracts and it flattens. And I feel like the verbiage on this used to get me confused because I'm always like, when I think flattens, I always think like that it's like relaxing kind of, so the opposite. But yeah, so the diaphragm, the intercostal muscles, they contract and basically you have more of a volume. When you're having more of a volume, you're gonna have a decrease in pressure. So I would just think about it. I kind of drew something to the side. So on the left side, you see that there's that box and then those little red dots, just think about it like air particles. If I have a smaller space, if you imagine those red particles moving, you would imagine the pressure is going to be a lot higher because it's a smaller space, right? Whereas when we're talking about the right box, you have a bigger space, a bigger box, and those particles between that would probably have less of a pressure versus the one to the left because you have more volume. And so think about it like with your vessels, when you're having vasodilation, you're having decrease in blood pressure because it's bigger. Whereas when you're having vasoconstriction, your vessels are tiny, so the blood pressure between that is going to be higher because it's so tiny. So it's the same thing with inspiration. If you're having bigger volume in your cavity, you're going to have a decrease in that pressure. And so remember that gas is being exchanged from a positive to a negative pressure. So because in your environment you have this positive pressure, and then now you have more blood volume, more volume in your thoracic cavity, you're able to inhale, and so that air is going in from the positive environment, and now it's going to the negative pressure in your thoracic cavity because again, it's in a negative state. So I hope that makes sense. Just remember it's going from a positive to a negative place. So in your environment, you're having that positive place. Your volume is being increased whenever it's contracting, and then you're going to have that air be able to come in because it has a decrease in that pressure. So positive to negative. So then when we're talking about inspiration expiration or exhalation is a process of breathing out, right? So basically the diaphragm and the external intercostal muscles, they relax, so they go back to their regular places. So now your thoracic cavity is smaller, so you have a decrease in your volume, but then you have an increase in the pressure. And so that pressure allows from the air to come in to be able to come out to your external environment. And then when you think about it, you're talking about pressure, right? So it's being able to come out. because you have an increase of that pressure. And then again, when you go back to the positive to negative pressure, because you have an increase in your pressure over here, and again in your environment, now you have a negative pressure, that pressure is able to come from a positive place, because again, you have an increase in the pressure because you have less volume. You're coming in and then you're breathing it out. So again, positive to negative pressure for that. And just think about it like with volume. So you're going to have a smaller volume on exhalation because, again, those intercostal muscles and the diaphragm are relaxing. So major function of respiratory system, ventilation, respirations, acid-base balance. And so we know that with the respiratory buffers, when we're talking about CO2, speech, sense of smell, and fluid balance as well. And when we're talking about oxygenation, again, we're talking about ventilation and perfusion. Perfusion meaning that we're talking about like perfusing organs, right? Like we're talking about on a capillary level when we're perfusing these organs between O2 and CO2 and getting rid of those waste products and then getting properly oxygenated. And then when we're talking about ventilation, we're talking about the actual movement of air coming in and out when you're inhaling, when you're exhaling. So ventilation perfusion mismatch. So what we're talking about for this is that there's a mismatch between what's going on when you're breathing in and out through your ventilation, and then perfusion, what's happening at that capillary level, and are you perfusing to your organs. So when we're talking about a low ventilation perfusion mismatch, and you don't have to know this in depth, but when we're talking about low, basically we're talking about that there's enough blood flow. So we're having enough blood flow, but we are more of having a ventilation problem. So, but air is not reaching that actual alveoli. And then when we're having a high ventilation perfusion mismatch, we're talking about the alveoli being ventilated, but blood flow is decreased. So like if we're having something like a PE, we're not able to have that proper blood flow, that proper perfusion, but we still are breathing, but it's not necessarily happening. Like those alveoli are ventilated, but the blood flow and that perfusioning is not occurring because of that clot being there. So you don't have to know that in depth, but just know again, like when we're talking about oxygenation, we're talking about ventilation and perfusion for sure. So oxygenation, oxygen diffusing from the alveoli into the blood, that oxygen attaches to hemoglobin and delivers that between the plasma so that again, it's able to go to those tissues and we're not having any hypoxia. So respirations, that's the transport of O2, and those are talking at a cellular level, and the transport of CO2 in the opposite direction. So you don't really have to know that, but just know like the mechanisms of how this stuff works, right? Like we want to be properly perfusing our organs through the blood, through the plasma, and we want to be able to also oxygenate or ventilate as well, because we need that oxygen. For proper oxygenation in terms of like the PaO2, SaO2, and SpO2. So PaO2 is partial pressure of oxygen, but this is basically the amount of O2 dissolved in the plasma. Whereas when we're talking about SaO2 and SpO2, this is the percentage of oxygen in the arterial blood. And so the difference between SaO2 and SpO2, and again, you don't really have to know this in depth. You kind of start to have to know it in like fourth, but SaO2, that's a little bit more specific because remember with SpO2, we're taking that on the finger, right? When we're putting the SAT on them. So that's in a peripheral level, whereas the SaO2 is talking about the actual arterial, so the actual blood. So you would have to do an actual like blood test for that, right? And get the blood and see what that level's at. So that one's more specific than SpO2, but they have different ranges, but for sure, SaO2 is more specific, whereas SpO2 is the peripheral one, but they literally are the same exact thing. They're just grabbing it from different places, right? One of them's peripheral, the other one you're actually having to look at the blood and see what the level is at for that. So yeah, like I just talked about hypoxia, so those tissues not being properly perfused and we're not getting the oxygenation, correct? So there's low O2, it's not meeting the metabolic demands of the cell, and then hypoxemia, there's actual low O2 in the arterial blood. So for dead space, when we're talking about dead space, we're talking about any place that is not being and participating in gas exchange. So that includes your bronchioles, that includes your trachea. So even though they are a part of your airway, like what is in charge of your gas exchange? And those are your alveoli, right? So when we're talking about factors like PEs or poor blood flow, we're talking about differentiation between that dead space. So for an example, with dead space, there's lack of perfusion in ventilated areas. So basically like a PE, you're having that blood flow and that perfusion being cut off to those alveoli, or to the rest of those lungs. So they're having a lack of perfusion, but that place is still being able to be ventilated because you're still able to breathe in and out. But receiving air, not blood, so there's an increase in dead space. So no blood is available to pick up those oxygenation. So remember, with oxygenation, to be properly oxygenated for your body, you need to be ventilated and you need to be perfused. So that is kind of what we're talking about for dead space. I don't think they'll ask you anything on it. Again, this kind of comes in fourth, but it's just basically talking about, again, what's participating in dead space, and that should be not your alveoli, but it also includes, we do need those alveoli to be properly perfused. And if we have dead space, those alveoli, yes, they're participating in ventilation, but they're not being properly perfused, like in places like when you're having a PE. Or let's say if you have hypovolemia, so you're not having enough blood to be able to even go to those sites. So then with the shunt, it's technically like the opposite. So the blood bypasses ventilated alveoli. So they're the right side of the heart to the left side without being properly oxygenated. So this happens in cases like ARDS, so like acute respiratory distress syndrome, which again you'll talk about in fourth, or let's say if the alveoli are collapsing, or if they're fluid, or if they're filled with fluid. So this prevents gas exchange. So basically, you're having those ventilated areas, they cannot be oxygenated because of the blood. So the blood that is not oxygenated due to ventilation issues. So now you're having ventilation issues with the shunt, because again, you're having enough blood flow, you're having that perfusion, but because you're not ventilating well enough, like with a case like ARDS, like acute respiratory distress, that blood is not being properly oxygenated as well because you're not even perfusing. So remember, like, you need to be breathing in and out, so you have O2 coming in, and then that blood is able to get oxygenated and picking that up between the capillaries and the alveoli. So if you're not having that being picked up, that blood isn't able to get oxygenated. So again, it's just kind of like, okay, how are we being properly oxygenated to the right side of the heart, to the left side, but we're not having proper oxygenation when we're picking up that O2. So I hope that makes sense. So to kind of like sum it up, so dead space, lack of perfusion in ventilated areas, whereas a shunt, the actual ventilated areas cannot oxygenate the blood, so we're having more of not necessarily a perfusion problem, but a ventilation problem, whereas with dead space, you're having more of a perfusion problem in a ventilated area. And so I won't go over this stuff because I feel like they won't ask you about it. I think the only thing with, and I don't know if I talked about it last time, but a bronchoscopy, you're having two different types, so a rigid and a flexible, and you don't really have to know that. But NPO 8 hours before, consent related to like the sedation we're giving them, IV access always, emergency equipment if they need O2 or suction just in case. And then you want to assess beforehand, are they having low BP? Are they already in respiratory distress, or are they having a low heart rate? After you're done with the test, you want to check vital signs, lung sounds, ANO status every 15 minutes until they're basically at their baseline or where they were at. For recovery, one thing that we're worried about is definitely with bleeding, because obviously we're literally going in the entire airway. And then for hypoxia, again, and then basically they need to remain NPO, because obviously we have like aspiration worries with that. And so they basically need to remain NPO until the patient is alert, and they have to have a gag reflex intact as well. And then one other thing just to know is they probably will have a sore throat, because obviously we're literally going in their throat. So that's really the only thing with that. I would recommend to read the aftercare in the book, just so you get that down. And then with a thoracentesis, it's just a needle inserted into the pleural space to remove a specimen or excess fluid of air. And so this can be done for multiple reasons, including a pneumo, a hemo, and pleural, but usually it is kind of more associated with a pleural effusion or anything like that. So now with I feel like with age-related changes, you don't really have to know that. And then now when we're talking about O2 devices, again, I feel like we studied it, but they didn't really talk about it. I think the only big ones is just maybe knowing like, yeah, a nasal cannula can also be a high flow as well. And usually the ones that we're going to use are a nasal cannula and a non-rebreather. But usually in the questions, it probably, if they're needing more air than a nasal cannula, you're probably going to be putting a non-rebreather mask on them, because that's what happens in real life. With non-invasive, invasive high flow, a Venturi mask. This is more accurate oxygen concentration because it can be adjusted. So with the color adapters, and I know Harding hits on this and she says to know it, but she literally didn't even test us about this. You're just having different FiO2s, different rates. And so that's definitely important when we're talking about, again, ventilating a patient, how much oxygen are they getting and what is the quality of oxygen that they're getting as well. So different adapters, and that's more specific to that. And that's the picture for that. So that's all you have to know about that she hits on, but I don't even think she'll ask anything about it. For trachs, T-pieces, what we're talking about is for a T-piece, it's mostly used to wean the patient off. And the reason for that is because it's usually a flow meter, I think is what they attach to the ET tube or the tracheostomy. So again, that's when a patient has to be fully ventilated, like they're not able to breathe on their own. So they have an endotracheal tube in their actual trachea, and then same thing with the tracheostomy, it's going down to the trachea, but it's bypassing this section. So you put a T-piece on them kind of when you want to have like a SBT, which is a spontaneous breathing trial. And again, you'll learn about this in fourth, but this is more just dealing with a T-piece. You hook up the oxygen to that so they're able to get ventilated, and we're able to see like, are they able to start breathing on their own? And so if we attach that flow meter, the oxygen device right up to their tracheostomy tube, or sorry, their ET tube and the tracheostomy tube, and we're trying to wean them off of oxygen after they've been ventilated, you have it hooked up there automatically. So how are you going to be able to see if they can breathe onto their own, because you literally have it hooked up like if they were ventilated? So the T-piece is kind of like an adapter that just lets you see like what's the difference. It's literally a tube, but it lets you see the differences with that. Like, are they able to start breathing on their own? Because you don't have it straight up hooked up to their tubes. So I hope that kind of makes sense. You don't have to know about that much, but it's kind of used to more of wean. And then for a trach collar, it's basically just attached to that. So it's obviously used for a tracheostomy, so it doesn't just move all over the place, because obviously you can just pull it out. And it's a little bit different than when you're with an ET2. You don't need a collar, and they still put one, but you don't need necessarily, it's harder to pull it out, right? Whereas with a trach, you can literally just, a patient can definitely pull it out. Whereas with an ET tube, it's literally in their mouth, so they're gonna have to really try, but still something to worry about. But really with the trach collar, you just want to make sure you're checking for like skin integrity, anything like that, and you will be able to change that out as well. And so yeah, I think that's all that really needs to know with that. For a face tent used for facial trauma, so if you see a question where it's like they're having burns, upper airway surgery, anything like that, put a face tent on them. That's going to be your first one. And so for a CPAP and BiPAP. So for CPAP, this is continuous positive airway pressure. So they're getting continuous pressure. So you guys haven't learned like what PEEP is yet, but that's basically positive. I always forget what it is. Positive pressure, expiratory pressure, something like that. But that's not right. The positive, whatever. But basically what it is that's keeping the alveoli open the whole time. So you want to keep the alveoli open in some cases. So let's say like if a patient is having obstructive sleep apnea, is usually the one that we use for this, they're not having proper oxygenation whenever they're exhaling, and probably whenever they're inhaling as well, because their airway is basically being closed off, right? So if we give them CPAP, they're not going to snore anymore because we're keeping that airway open the entire time. So that alveoli, they do collapse. And again, you have that surfactant to prevent them from collapsing, but we want to keep the alveoli open the entire time. So that's what continuous positive airway pressure is. And so I guess the question could be like, why do we ventilate patients whenever you can just keep them on CPAP? So usually before we ventilate patients, and that's like when they absolutely are in like acute distress, respiratory distress, right? Like whenever they cannot breathe on their own, you see that a patient's really struggling and they cannot breathe on their own, even after you put a mask on them, even after you put like a nasal cannula on them, you can go ahead and probably put a CPAP on them as well to see if that's going to help. So the reason why we don't just use CPAP for all ventilated patients is because that also we don't know what volume of oxygen we're giving them. Like we don't control their volume, we don't control the rate. So again, like CPAP is great. And so with like an obstructive sleep apnea patient, they're having that alveoli and their airways closed off, but and we want those alveoli to be open so we can have proper gas exchange. But the problem is that they can still breathe, right? Like they're not dying. Like they can still breathe on their own. Like even with like obviously they're not getting the best sleep probably, but they can still breathe. It's not going to kill them. But with like a ventilated patient, obviously if they're having acute respiratory distress or respiratory distress in general, they're not able to breathe on their own. Yes, you can put them on CPAP, but at the end of the day too, you're not controlling what rate you're giving them, you're not controlling what volume you're giving them, and there's a lot of different other things that I don't necessarily want to bring up just because you haven't learned about it, but you want to control different settings on an actual ventilator, which you can, whereas with CPAP, you're just keeping those alveoli open the whole time. And sure, that's great, but at the same time, there's other issues that come into play when a patient cannot breathe on their own. So like with CPAP, like again, with sleep apnea, it's like, okay, they can breathe on their own still, like they're able to physically breathe on their own. But with a ventilated patient, those patients are not able to breathe on their own, right? So with a BiPAP, this is bi-level positive airway pressure. So the difference between that, it has two different settings on when you're inhaling and then when you're exhaling, right? And so basically positive pressure at the end of exhalation along with higher positive airway pressure during inhalation, so better oxygenation. And so this basically helps patients, especially whenever they need to exhale that CO2 off. Like, so basically like with COPD, right, we know they have higher CO2. So this is to help with that exhalation to go against like the pressure that's happening whenever they're just breathing on their own, because it's hard for them to breathe off because of the pressure that's happening with inspiration and exhalation. So that's why we give them BiPAP, so it's able to help breathe out that CO2 as well as make sure that they're also being properly oxygenated on the way in as well. So with an ET tube, this is what I was talking about. This is when we're actually like, we're intubating the patient. And again, a tracheostomy is basically the opposite of that. So an ET tube and a tracheostomy are technically the same thing, they're just different places, right? So it's going to be inserted through either nasally or orally. So you have two different things, but this is basically when we want to keep the patent airway. And then we'll get to that in a second. And then for a tracheostomy, this is basically the same exact thing, but replacing with an ET tube. And so somebody who, let's say, needs to be having a longer term ventilation, we're probably going to give them a tracheostomy rather than an ET tube, because that's more short term. And the reason why is because, again, we're trying to prevent upper airway damage as well. So there is a decrease in airway resistance and decreased workload as it literally just enters the trachea automatically, whereas with an ET tube, you're having to travel that whole entire way. So advantages is that they're able to have more comfort, more safety. It's an improved oral care because, again, it's not going through their actual mouth. Improved access for removal of pulmonary secretions because you're actually able to suction, and you can with an ET tube as well. And then with disadvantages, you're just limited to communicate and you have complications, but obviously with an ET tube, you are having limitations to communicate, obviously, because it's literally in their mouth. So in terms of home care, one thing that we definitely want to look for, and I will send you guys this PDF without all of my highlights because this is from whenever I did this. So whenever you're suctioning a patient, so in terms of tracheostomies, in terms of ET tubes, you need to be checking their oxygen saturation during that, if they're having any decrease in heart rates or anything. And if they do, you better stop suctioning them and you're going to put them back on 100% of oxygen. So for trach care, one thing to know, and I feel like you can just go over these in terms of cleaning, in terms of what has to be sterile and what doesn't, but they don't really ask this. It's just something that you probably should know. So definitely try to read about this. And then obviously with suctioning, you have different things here. So remove the oxygen device and provide 100% oxygen with an ambu bag, right? And you're going to hyperoxygenate them. The book says 4 to 6 breaths. You're going to apply suction and you rotate as you are withdrawing. And you want to make sure that the maximum you're doing this is only for 10 seconds whenever you're suctioning them and only on the way out. You're reoxygenating them after you suction them with, again, 100% FiO2 with the ambu bag, 2 to 3 breaths. And so it's just saying 4 to 6 breaths before you actually suction them. And then if they're still present, you can repeat this about 3 times. And then you give them a rest period in between of 20 to 30 seconds. So it's a lot of memorizing. So I would just think like before, you're going to probably hyperoxygenate them 4 to 6 breaths, right? You're going to double it. And then in between your suctioning, 2 to 3, only on the way out, you're going to suction. You're only going to do it for 10 seconds. You're going to Then do it 3 times if they really need it, and then you give them a rest period of 20 to 30 seconds. And I would just think about it like when you're actually oxygenating them, you're re-oxygenating them each time with 2 to 3 breaths, and then you're going to give them 20 to 30. So just add zeros onto the end of the 2 to 3 breaths for the time. And then also document that you did it. What are their levels at now? Are they able to breathe better? Are they having a better SaO2, SpO2? And so, yeah. So with complications, you can have accidental decannulation. I always have struggles like talking or saying that word. So this is within the first 72 hours after their procedure, and that is a medical emergency for sure, because now their trachea is just open and now you're just having air come out, air come in. So a pneumothorax, collection of air in the pleural cavity. So you're having a buildup, and we'll talk about it in a second, a buildup of that air. So you have a collapsed lung. And then you're having a subcutaneous emphysema, which is a puncture or tear into the trachea, and air moves into the surrounding tissues. You could have infection because obviously if you're cleaning it, if you're suctioning, you're not using aseptic technique, anything like that. You can have tracheal stenosis, so narrowing of the actual trachea because of the inflammation and irritation that's going on. And then a tracheoesophageal fistula, and that can develop basically as a result of inflation of a tracheostomy cuff, and the excessive pressure can cause a fistula, which is a hole, to occur between the trachea and the esophagus as well. So just things to note, but really the biggest ones are probably pneumo, and then probably a decannulation, and then probably an infection, because you're just not, obviously she might ask you about care and all that stuff, and you might not be aseptic with what you're doing. So with oxygen toxicity, we're definitely worried about giving them too much oxygen because of the concentration of oxygen you're giving them. So again, like with FiO2, you're giving 21% at room air, and so you can give them more concentration. Which we're talking about quality of oxygen we're giving them. We're not talking about the actual volume. We're talking about the quality when we're talking about the percentage. So with absorption atelectasis, we're talking about high levels of O2 are administered, which is causing the alveoli to collapse. And this is because it also deals with nitrogen when we're talking about this, because I had to look this up because I was like, okay, but sometimes if we are administering high levels of O2, and this is talking about concentration, the alveoli are going to collapse because that gas exchange that's occurring, what keeps the alveoli open? Nitrogen is also a part of that. So nitrogen and O2 are able to keep those alveoli open as well. And so I think it basically said, I had to ask the internet, and I think it said that, let me see if I have it here. I have it somewhere because I wanted to be able to explain. I try to go deep into some of this stuff so you guys can understand like why is that the case for that. So let me see here. Let me pause really quickly. Okay, so yeah, I found it. Okay, so because I had a bunch of notes to the side right here to make sure that I'm also explaining things right. So alveoli can collapse due to the high levels of oxygen in the specific context known as absorption atelectasis. Okay, so with high concentration of oxygen, a patient is given supplemental oxygen, especially in high concentrations. The oxygen in the alveoli can be absorbed into the bloodstream more rapidly than nitrogen, which is normally present in alveoli. So with nitrogen's role, under normal conditions, the air in the alveoli is a mixture of gases, primarily nitrogen and oxygen. Nitrogen keeps the alveoli inflated because it remains in the alveoli and contributes to maintaining alveolar pressure. If a patient breathes in that high concentration of oxygen, the oxygen can be absorbed into the bloodstream very quickly. So again, we're talking about concentration of oxygen because that's capillaries are going to pull that up and absorb into that bloodstream, so they're able to get oxygenation. But this leads to a decrease in the actual volume of gas within that alveoli. So if the oxygen is absorbed but not replenished due to the lack of ventilation obstructions, or if they're just having low volumes of breathing in, the remaining volume of gas can drop below the critical level, needing to keep the alveoli open. So basically, it's just talking about because you're giving them so much concentration of oxygen, the capillary is going to pick that up. It's going to go to the bloodstream, but it's not remaining in the alveoli, so they're going to collapse. So I hope that makes sense with that. And then nitrogen just plays a role in keeping them open. And then you have less nitrogen, you have more oxygen, but that oxygen is also going away as well. So again, those alveoli aren't going to be able to maintain that pressure because it has to be those two for that. So with so that was a little bit more than you need to know, but just know that like yes, you can give too much oxygen concentration, it can lead to other complications. So with sectioning, one thing that you want to make sure is that again you're looking at their SpO2 when you're doing that. Audible or noisy secretions, this is what you can hear. If they're having crackles or wheezes, that probably needs to indicate to you need to suction. Also, if they're having restlessness, for sure. And then if they have an increased pulse or respiration rate, and then after you suction, are those things gone, or do you still need to notify your provider that things are going on? Do you still need to tell your RT what's going on with that? So let's see here. I think is this. Oh yeah, okay. So laryngeal cancer, number one, always going to be smoking, and especially when we're talking about the laryngeal place, right? Because we're talking about hello, where that airway's at. And so if they're smoking, obviously it's going to definitely be compromised. So tobacco, alcohol use, poor dietary habits, GERD because of the acid that's going on in between your track. And then when you're talking about compromised immune systems, genetic syndromes, occupational hazards, gender, age, race, we're all talking about things that are out of our control, but at the same time, all of those carcinogens you're more exposed to. So with patho for that, that's just changes in your squamous cells from irritation and can result in the cells becoming precancerous, and then obviously they can become malignant after that. So manifestations for this, I feel like they will test on, and again, I'll make a Quizlet for that. So hoarseness, change in voice for sure, because again, we're talking about your laryngeal tract, and then lower pitch voice than usual, doesn't resolve in 2 weeks though. Persistent sore throat, constant cough, pain with swallowing, ear pain that doesn't go away, difficulty swallowing, trouble breathing, a lump in the mass or neck, and weight loss due to difficulty eating. And so some of those again deal with, I feel these are all pretty much related to actual like laryngeal tract like cancer. But again, like with a lump or mass in the neck, that can technically associate with other things too. But remember, you can have a growth that you see there with the caution signs, and then the weight loss as well, with anorexia, anything like that. That's kind of more of a general cancer symptom. So again, it depends on what's going on. It depends on what's the size. It depends on the location, what's going on. So again, they can have radiation, surgery, and chemo. And so this is just going over some of the stuff to know about radiation and chemo. And then additionally, throat care and surgery care after. So surgery, they can have a laser surgery, a chordectomy, or a partial laryngectomy. So they're taking out either partial of it or total of it. And so if that's the case, they're having a total, you're going to be able to communicate to them that you would need another way of communicating completely. So they have boards that they can draw on. They have with their phone, anything like that. And then a radical neck dissection, which is whenever you're taking off those tissues and lymph nodes specifically. And so I'll send this to you guys again, but just definitely read on it. I have stuff highlighted. So if you want to like look at it, what I have highlighted, I'll try to give you guys a blank one as well. But that is radiation, and then therapy care. We're taking about skin care, oral care, throat care. So I think with that, that's usually the ones that we have to know. So limit voice, eat soft foods, drink plenty of fluids, sucking on ice chips or saline, gargling can also decrease your discomfort. Using throat spacer or mouthwashes can contain that contain a local topical anesthetic prescribed by a provider may relieve a sore throat, but it should also be provided by a prescriber, or they have to check with them first. And then for chemo, you can take antiemetics, avoid crowds, again, report increases in bruising because of all of the decrease in platelets, decrease in WBCs, and then presence of blood in the urine or stool, obviously with that. And then for communication management, you have the writing or picture boards, you have esophageal speech or electrolarynges, because again, with the vocal cords, you're having a loss of that whenever you're taking that out. And so let's see here. And then right at the end, esophageal speech occurs through the use of swallowed air to create words in the mouth. And then electrolarynges are mechanical devices that are placed on the neck and use vibrated air to create words. And then at the top, that's just also talking, I think, some more about tracheostomy care. So for lung cancer, it's going to be the same thing. it definitely is more of one of the common cancers, number one cancer with the highest mortality. And again, because I think it has to do with your respiratory system, right? And so age over 50, exposure to smoke, exposure to radiation or inhaled irritants, and exposure to radon. So you can have uncontrolled growth of abnormal cells in the lungs. So we know that with cancer, they just don't care about what they're doing. They're just going to grow wherever they want, do whatever they want. So you have two types. It's non-small cell versus small cell. I don't think you have to know that, but it says that on there. For manifestations, it's not apparent at first, and then you end up having a new cough that doesn't go away. You're coughing up blood, which is called hemoptysis. Hemop I don't even know how to say that. Hemoptysis, I think. Shortness of breath, wheezing, hoarseness, chest pain, headache, and bone pain as well. And so remember, like with bone pain, I think lung cancer is one of them, right? So that can lead to bone complications and musculoskeletal complications as well. So diagnostics, chest X-ray, CT, and PET scan, same thing that always what you're going to do for cancer. Sputum for cytology, bronchoscopy, bone and abdominal scans. It's going to be the same thing basically every time. Really, the one thing to know about this is probably just the surgery aspect. I feel like for this one and for the laryngeal cancer as well, is just because what are you going to remove and what's the care that you're going to follow up with. So obviously with this, we're not talking about the laryngeal tract, we're talking about the actual lungs itself. So lobectomy, which is removing the cancer cells in one lobe, if that's what they have, right? But let's say if it's more malignant, it's able to get to both of their whole entire lung. You can remove the cancer cells by removing the whole lung. And then a wedge resection, you're removing cancer cells, but localized in one small area of the lung. And again, you can still do radiation, you can still do chemo and everything. So just read on the pre and post, but I feel like again it's going to be the same thing. If they have a chest tube, they have a chest tube. If they're mechanically ventilated, check what's going on. Do they need pain meds? Do they need assist on like turn, cough, deep, breathe? Are they having or developing an infection, especially if they're ventilated? And then also assist with early ambulation, maintain nutritional status. We want to prevent aspiration, and we also want to prevent pneumonia as well if we don't get them up and if they're not breathing properly. Okay, so for chest trauma, this is probably what she's more of gonna hit up on. So for chest trauma, so motor vehicle accidents are probably the most prevalent cause. So this goes under multiple things. So chest trauma, this is just like an overall, like, yes, this goes under chest trauma, right? So flail chest, pulmonary contusions, and then pleural space disorders like pneumothoraxes or hemothoraxes. So those are the three that go under chest trauma, really. You'll see a flail chest, a pulmonary contusion, so you just had something happen to you with the chest trauma, obviously probably not good, and it can lead to a pleural space disorder like a pneumo or hemo. So with the flail chest, it's, I think I put it wrong on the study guide, it should be 3 or more adjacent ribs that have been fractured in 2 or more places. So it's 3 by 2 is what I would remember for that. So one thing is that the manifestations, and you do have to know this, is I'm going to talk about the flail chest ones first, is the paradoxical movement that happens. So your flail segment is sucked inward during inhalation and moves outward during exhalation, right? So you don't necessarily have to know that, but just know that inward inhalation, outward during exhalation, but you're having paradoxical movement. So what's happening is that those flail segments that you broke, so your ribs, are having a weird chest wall movement or the opposite of what is normal. So you're having difficulty breathing, makes sense. Pain, of course. You just had something break in you. Diminished breath sounds, and then palpable crepitus. So it sounds like Rice Krispies. So if you're able to like palpate their chest, you'll be able to hear those sounds, right? So with rib fractures, the difference between flail chest and ribs is that you probably will not see, and you shouldn't see, paradoxical movement, because that doesn't mean that that's happening. That just means something happened with the rib. So your pain on inspiration still is going to happen. Coughing, diminished breath sounds, same thing. So they can be rapid, but shallow, which again makes sense because you're trying to breathe in as much as you can, but shallow because it hurts. Bruising over the fracture, and then you can still hit crepitus as well. But yeah, definitely for flail chest, just know that you're having that paradoxical chest wall movement. For pulmonary contusion, we're just talking about like you got hit. And so something I always think about is people who get kicked in the chest by like a horse or something. Like, and there's a specific name for it. So one thing is that you can definitely have chest trauma, and this can lead to a pneumothorax. This can lead to hemorrhages, which can then lead to a hemo. So one thing is that you can see shortness of breath, and this usually occurs 12 to 24 hours after the injury, restlessness, because again, you're having a hard time breathing, apprehension, chest pain, copious sputum, tachycardia, tachypnea, dyspnea, and cyanosis. So again, this all has to deal with like shortness of breath, right? And you're not being able to breathe because of your chest trauma. And so this can happen unilaterally or bilaterally. So with a contusion, the alveoli and pulmonary arterioles rupture, which cause intra-alveolar hemorrhage and interstitial and bronchial edema. So you just want to make sure that they're being able to be monitored, see what's going on, but they will just need healing with that. And that does happen with time, but obviously treat your symptoms. If they're having difficulty breathing, you can put them on oxygen, but it's not necessarily as traumatic or difficult or challenging than probably a pneumo or a hemo, but it is still something that you want to watch out for. So for manifestations, overall with chest trauma, we're talking about decreased oxygenation and ventilation, right? So you're not able to fully get that gas exchange. So again, at first you're going to have a higher respiratory rate, and then it's going to eventually probably slow down and be a little bit different in terms of the acid-base balance. So you're going to have respiratory alkalosis first because you're having a rapid inhalation and expiration, right? So you're getting rid of all of that CO2 on exhalation. But basically, respiratory acidosis then occurs because eventually what will happen is your CO2 is retained and it isn't being properly exchanged. So you can always check out for like a chest X-ray, ultrasonography, ABG, serum lactate. It should say H&H, and then obviously, yeah, CBC, anything. So I'm trying to see here. I think that goes with the other thing. Okay, yeah. So treatment, use ABC acronym. If they're not able, if you know all of a sudden they're not being able to breathe, okay, you can probably put them on a CPAP for a second. And then after they're not able to breathe on their own, nothing's happening, they're not being able to breathe, you have to prepare them for intubation, right? One thing to know for treatment, and that's why I have it highlighted up there. So basically, an early sign of hypoxemia, so enough, we're not talking about the tissues, we're talking about the blood with this and the plasma. So the blood isn't properly oxygenated. You can see agitation and anxiety. Then you're having a decreased level of consciousness because of that perfusion. And then the patient typically reports shortness of breath, subcutaneous emphysema, or air in the tissues under the skin. That's what subcutaneous emphysema is. And that can occur with blunt trauma. And then also they can end up developing a pneumothorax. So pain is a common manifestation, is what we saw also with like the rib fractures in the flail chest. So you want to be able to give them pain medication as well, because if they're having pain, they're not able to get proper oxygenation, and eventually they can actually have pneumonia, obviously, because they're not breathing in fully and expanding those lungs as they should be. So the patient may experience splinting. So that basically is whenever they're having posture around the site of the injury, if their arm is going to the affected side of their body, if their patient is bending to try to basically help them out with their pain or try to help them out in terms of how they're breathing, just make sure that's not, we want to prevent that from happening, because again, pneumonia can happen with that because their lungs aren't fully expanding. So again, we give analgesics because with the pain, they might not be able to breathe fully because it hurts, which leads to alveoli collapsing, which they're not opening. And so basically, we also want to watch out for pneumonia for that. So complications are a tension pneumothorax and then a cardiac tamponade, which we'll talk about today as well. So it says right here too, at the top of the medications for the pain meds, a regional block or epidural analgesia may be administered to reduce pain without the narcotic side effects. This allows the patient to breathe more effectively. If there is penetrating trauma, the patient is at an increased risk of an infection. We'll talk about that when we're talking about traumatic pneumothoraxes. And so you want to give them antibiotics for that as well, because if they're having something go in them, yeah, it's definitely not a good thing. And so we're talking about like motor vehicle accidents, being with chest traumas, and probably the most associated with, especially with traumatic pneumothoraxes, something's going in their actual chest wall. So we want to be able to prevent an infection. So pleural space disorders are basically diseases and conditions that cause the pleural space to fill. And as a result, most likely what's going to happen is that the lung is going to collapse right next to it because of what's happening to that pleural space, and the fluid shifts, or not fluid shifts, but necessarily the shifts in gas exchange in air. So with a pneumo, this is a collapsed lung that results from a severe blunt or penetrating chest trauma, which there is a disruption of integrity of lung parenchyma. I don't know how to say that word, but basically this is thin-walled alveoli, and so they have more surface area, so it can be opened or closed. So this is just overall what we're talking about right now. It's just pneumothorax is collapsed lung. And so pneumothorax manifestation, it's going to be with all of them, most likely. Sudden shortness of breath, decreased breath sounds on the affected side. Because obviously, if you're having one collapsed lung, are you going to be able to hear that lung? No, probably not. Decreased chest expansion on affected side, tracheal deviation to unaffected side, and that is more with tension pneumothorax, and then chest pain. But this is just overall what it's saying. So really, the ones you have to know is just spontaneous tension and traumatic. For spontaneous, this is when there is an air-filled bleb or a blister on the lung surface. And so this then ruptures, which allows air from the airways to enter the pleural space. And as it enters the pleural space, that's also going to have that lung collapse as a result. So one thing to note, this happens in tall, slender men. Definitely weird. So if you see a question where it's saying a patient comes in, a male patient comes in who is like 6'3", or not, is that tall? I think so. But if you see a tall person, obviously, in that question, it's probably going to be a spontaneous pneumothorax. So primary risks and secondary risks are associated with this. And so secondary is more related to conditions, whereas these primaries are more related to environmental changes and things that you do, like smoking, anything like that. So manifestation, shortness of breath, increased heart rate, increased respiration rate, asymmetrical chest wall movement, and then diminished or absent breath sounds on the affected side. So I feel like, again, it's like the same thing. So for traumatic pneumothorax, it's a blunt or penetrating trauma of the chest wall. So something's happening, it's coming in, so you most likely have to give them antibiotics. So it's, again, similar to a spontaneous pneumothorax, but it can be overlooked if it's subtle and masked with primary injury. So when looking at all of these, the one that is the worst is definitely a tension pneumothorax. And so the reason why is because your lung can actually pop and like rupture. And it also leads to some heart damage and ischemia as well. So tension pneumothorax occurs if air or blood collects in the pleural space, but it cannot escape. So the pressure rises rapidly with each breath, and the lung on the affected side collapses. And the pressure on the mediastinum then shifts, and that's in between your lungs, right? So then the thoracic organs shift on the unaffected side. So that's why the heart is usually affected with this. And then ventilation is severely compromised, and then blood flow is impaired to the heart because of that. So tension pneumothorax is basically like a buildup of air is how I think about it. Literally cannot escape. So it's like a pneumothorax. But one thing that you are going to see with this, which differs, is you're going to see some of those, that hypotension because of the blood flow not being able to get to the heart, distension of your neck veins. That's usually the big one. And then as well as tracheal deviation is going to be one of the biggest things for a tension pneumothorax for sure. So make sure you know that. So tracheal deviation, and then hypotension, and then distension of the neck veins. And then they can get into a shock state. And so for hemo, that's just talking about now you're having blood in that pleural space. And then again, as a result, now you have a collapsed lung. So with treatment, this is bed rest, limited physical activity, and so they're going to get a chest tube. So with a chest tube, before you're going to get consent, tell them about the procedure, and that's with the provider, right? You witness that. Positioning the client, so 30 to 45 degrees for the head of bed, assisting with the procedure as necessary if you're involved within that, which you will be as a nurse. So post-procedure care, I'm going to talk about the things to know with the chest tube, and I'm trying to summarize it. And then respiratory status, maintaining a closed chest tube drainage and apparatus, assisting with position changing, sterile occlusive petroleum jelly dressing, post chest tube removal, and then after the chest tube is removed, arterial occlusive petroleum jelly dressing should be applied. Okay, so it's basically the same thing. But to explain what's going on with the chest tube, okay. There are only like a couple things you really have to know with the chest tube, and so I'll try to explain it all. And again, I'll send you guys like this the stuff in the book. Again, I have my stuff highlighted. I can take it off. But basically, I would recommend to read on it because it does help. But you're gonna have certain things that you cannot do with the chest tube. The way that the chest tube works out, and it actually has it under here, is you have a collection chamber, a water seal, a suction control chamber, and then those other things. But really, the way that I think about it is you're having a tube that's going to be placed in their chest, right? Um, to be able to remove what's going on. So if they're having a hemothorax, we're going to move the blood out. If they're having air, it's going to remove the air out. But basically, the way that it works is, remember, we're talking about going from a positive to a negative pressure. By having that water seal, and we'll talk about it in a second as well, but when we're having that water seal acts as a negative pressure because, and this is basically what the entire drainage system is we're talking about with that water that acts as the valve, because then we're having the negative pressure in there, because again, in water, we're not having air in there, right? Versus like our lung being the positive pressure. So we're going from a place of positive to negative. So that's why it's able to come out. So you don't have to know those systems or like how it works in depth, but I feel like if you understand it, it'll make sense. So for a chest tube, if you see bubbling, and I think she explains it in a way where, like, if you see bubbling, that's a bad thing, but that's not true. So if you see bubbling on exhalation, that's pretty normal. If you see intermittent bubbling, that's fine. You don't have to freak out. It's the continuous bubbling that you should be freaking out for, because now that means that your air tube, there's probably an air leak. So is it tubed? Is the tube kinked? Is something going on? Check out the tube and see what's happening for that, right? So continuous bubbling is where you are worried. So then also, if the tube comes out of the patient or the tube is disconnected. So those are the other two things. So if the tube comes out of the patient, so it's still attached to the drainage system. It's still attached to the drainage system, but it's out of the patient. What do you think you're going to do? Yeah, you're going to put the dressing on them. So you're going to put the Vaseline or the petroleum jelly on the gauze, and that acts as a valve, or like as it kind of acts as the negative pressure seal, kind of, because that gauze, it still has like holes in it, it still has like room to breathe and be able to have gas exchange, but because you're putting Vaseline on that, it's thick, right? So it's going to cover that. But when you're taping it, you want to tape it 3 ways, not 4, because you need to have air still escape, because if you have it all closed, they can get a tension pneumothorax for sure. So you're having buildup of air with tension pneumothorax. So just know that you need to tape it 3 sides, but you can leave a bit of it out because we need some of that pressure to come out. And so again, it's acting as a negative pressure seal, kind of. So you're not having air just come in and out. You're having that air come out still, and again, you're not having the air come in. So that's why we do that. But just know, if you're going to put gauze on them, you're going to put the petroleum jelly, and you're going to only tape it 3 sides, but you're doing that if it gets disconnected to the patient, not if it gets disconnected to the drainage system. So now, if the tube, you walk into a room, and now let's say the tube is disconnected to the drainage system, but it's still connected to the patient. You're going to get the sterile water, and you're going to get that bottle, and you're going to put that tube into the actual drain. Into the actual sterile water. And the reason why is because, again, we're talking about air and gas exchange happening from that gas being able to go from a place of a positive pressure to negative pressure. And so all of that air, and again, this is essentially what the drainage system is doing, all of that air and or blood or whatever's in the lung that we want to get rid of with the hemothorax, pneumothorax, whatever, is able to go into that bottle or in that drainage system, because again, it's having negative pressure within that water. So that's why you put it in there, because again, you're going from a positive to negative place. And so it's not going to be able to come back in because it's still negative, positive. That water is underneath it. So if I just had a tube and I just put it in the environment, obviously air can travel out of it, because I'm inhaling and exhaling what's going on regularly of what we're doing in our everyday lives, right? Like I'm inhaling, exhaling right now. So the process of that positive and negative pressure changes, right? As I inhale and exhale. But with that sterile water or with that drainage system, that water basically allows that tubing system to always be negative. And so that's why we're going from a place of positive, which is ourselves, to the negative pressure. So that's why with the chest drain or tube, you're having all that stuff come out. So that's why you put it in sterile water. So again, if it comes out of the patient, you walk into the room, you see that the tube is out of the patient, you're going to put the gauze on them. And then they're going to have to get a reinsertion of the tube. But don't Just put gauze on it. It has to be petroleum jelly with it, and then it has to be taped 3 sides at least. You need to leave one out. And then if you come into the patient, you see that the tube is disconnected to the drainage. Okay, then you're going to put it in sterile water because again, you need that negative pressure back. And then the last thing to know with the chest tube, never ever clamp the chest tube. That is not your thing. In some cases, I did ask on the internet, like, but in some cases, if they don't necessarily need a chest tube anymore, couldn't you just clamp it? But that's not in your protocol. Don't do that. The MD will determine that and do that themselves. So never clamp the chest tube because you can lead to a pneumothorax, right? Because you don't know if they still actually need the chest tube. So leave it in them. Don't clamp it because then if you clamp it, all of that air and all that stuff is going to remain inside. And now you're building all of that up and we were getting rid of all of it. And so now it's building all up again. Now you got tension pneumothorax. So yeah, I think that's all to know with that. And it says it all in there. And then another thing to know, usually, another thing, always keep the drainage system below the patient, right? You never want to put it higher, and that makes sense. Because obviously with gravity, and obviously it's going to come back down to the patient. Let's see here. Yeah, you can give them pain meds because it does hurt. For hemothorax, oh yeah, it just specifically says a hemothorax, you want to place it at least lower between the 5th and 6th intercostal space as well. And then because of the pneumothorax, because air rises, the chest tube is placed high, usually in the 2nd or intercostal space of the midclavicular line. So that's not talking about the drainage system. You should always keep the drainage system below the patient. But in terms of like the actual chest tube, just know that it's going to be lower for hemothorax to drain the actual blood. And because again, air rises, it's probably going to be higher with the chest tube. And then with this question, a nurse understands that the priority action for a patient with a chest tube that has come disconnected from the chest drainage system, and which of the following: immediately cover the end of the chest tube with sterile dressing. Okay, so the chest tube has become disconnected from the chest drainage system. So it's still in the patient, but it's disconnected from the drainage system. So immediately cover the end of the chest tube with the sterile dressing. Well, that's not even an option because you know that you should be covering the patient with the sterile dressing. Immediately reconnect the end of the chest tube with the drainage system. No, do not do that. Not in your protocol. Do not do that. Immediately page the provider to insert a new chest tube. That is true. You do need to notify them. But is that the first thing that you're going to do? Absolutely not. So immediately submerge the end of the chest tube in sterile water because, again, you need that negative pressure to happen. So that stuff that's coming from your lungs, the hemo, the air, whatever it's going on, you're having all of that come back out and go into act as that drainage system essentially. So other thing to be noted is red free-flowing drainage in excess of 70 mLs per hour needs to be notified. The provider needs to be notified for that because that can indicate bleeding and then cloudiness. We always know with cloudiness, that's an infection. So red drainage in excess of 70 mLs per hour, definitely need to be notifying them about that. And then cloudiness as well. And then again, one more time for a water seal chamber, initially there is bubbling on expiration. So that's why, again, if you see bubbling on expiration, not that big of a worry, that's fine. Indicates that the air is removing from the pleural space. But if there's continuous bubbling, then that's where it's like there's an indication of an air leak. Like that's too much. Basically, you're losing too much air. So what's going on? Yeah, I think it's pretty much it. I think, yep, never clamp the chest tube. Clamping the chest tube may be resulting in the air or fluid collection space. So that can lead to a tension pneumo. When the chest tube is removed, immediately apply a sterile occlusive petroleum jelly dressing. So if you have to remove it, the provider says we don't need it anymore, just apply it. Or if it's disconnected to the patient. And so an occlusive dressing prevents air from re-entering the pleural space through that chest wound of what was going on. But it also allows for air to come out. So with pleural disorders, the last thing I'm just going to hit on is inflammation of the pleura with pleuritis. And I would just think about it, these are just talking about kind of like inflammation, right, of the pleural space. So pleuritis, exactly what it is, inflammation of the pleura. And so you're going to have unilateral, well-localized, sharp, and stabbing pain. I feel like that was something that I think she might have asked, but I don't really remember. I'll have to check. But usually occurs secondarily to another process like a viral respiratory illness. And I feel like whenever you're having those itis So that's inflammation. It's usually associated with some type of infection. So pneumonia, again, infection, or like a rib injury as well. Because that's going to cause inflammation of the pleural space because that's in that region. For manifestation, it's pain aggravated by deep coughing, breathing, movement, breath sounds are diminished, of course. Pleural friction rub. So you're going to hear like that rub between that, and then rapid shallow respirations. Limitation of chest wall movement, diminished breath sounds. So yeah, I just feel like the one important thing, inflammation of the pleura, it's unilateral, sharp stabbing pain, well localized, pleural friction rub, and then rapid shallow respirations. For pleural effusion, we're talking about excess fluid in the pleural space. What there isn't lung collapse. So pleural effusion can lead to like a pneumo, can lead to like a obviously a pneumo can then lead to like a tension pneumo, all those things because you're having a buildup of that fluid and now like your lungs can be affected. But pleural effusion doesn't mean that the lungs are collapsed yet. Like the pneumo is specifically saying the lung is collapsed. So pleural effusion can be from transudate. So that's fluid that passes through membranes, has fewer cellular elements than exudate, and formed when capillary pressure is high and plasma proteins are low. You don't have to know that. And then exudate is the other option that pleural fluid may be. So any fluid released from the body with high concentration of protein, cells, solid debris, exudate is result of increased capillary permeability. Don't have to know that, but those are usually what the fluids are, is what they're talking about. And then emphysema, which I think I spelled that wrong, is just a collection. I just said emphysema. Empyema, is that right? Let me check for that. I think that's right. But collection of pus basically in the pleural space, and yeah, that should be right. So then with the thoracentesis, I just saw one in the cath lab literally like 2 days ago or a day ago. So basically, the provider's going to insert a needle between the ribs and into that pleural space to withdraw the fluid. And so the question is like, couldn't they technically do this with the hemo, with the pneumo and all that stuff? Yes, they technically can, but remember with the hemo and with the pneumo, it's like a continuous thing. So if they just did a thoracentesis or like a hemo and a pneumo, technically you could, but that's not solving the issue of what's going on. So they're going to continuously need that drainage so all of it can come out. It's for a thoracentesis, this is like a one-time thing. And then a paracentesis, that's the same thing, but just, it's called the same thing. Paracentesis, same thing. So yeah, I just put it on the side, usually just for pleuritis or pleural effusion because you're having a buildup of that inflammation of the pleura, or like with a pleural effusion, you're having that actual fluid. But like with a pneumo or a hemo, they need continuous draining like a chest tube. So that's why you don't do that. So again, pre-procedure, you're going to check all their vitals, you're going to apply a dressing, position the client on the unaffected side, and usually like you might even have to have them like go over a table, kind of sit up if it's going to have to be in the back, and then position the client on the affected side, sending specimens to the laboratory if you need that. And then you're going to monitor like how much do they even how much came out, and then again, those vital signs and everything. And then a pleurodesis, this is different. This is to prevent a pneumo or a pleural, because again, you're having a collapsed lung that's happening with the buildup of either fluid or blood or anything like that, or just air. And so chemicals are introduced into the pleural space with the pleurodesis. So it's actually having a chemical, and I think it says like one could be like doxycycline or other things, but basically this irritation from the chemicals causes the layers of the pleural to actually close. So that's why a pleurodesis can be used for like a pneumothorax, because it's actually closing and fixing that problem. Because again, a pneumothorax can occur and so a pneumothorax, a collapsed lung, can occur because of what's happening with the pleural space and the difference of pressures between that. And so if you're able to close that space and prevent further accumulation of fluid or air or whatever, you're going to prevent that pneumothorax from occurring. Whereas with like a thoracentesis, you're just removing that air, removing that fluid, but you're not fixing the actual pleural space problem that's going on. So that's why a pleurodesis can be used for a pneumo. And again, it can be used for a pleural as well, because you're closing that up so all of those fluids can't necessarily be exchanged through that space. So painful, so yep, pre-medicate in that pleural space. Sometimes they can use an epidural catheter for anesthesia. And then there's just surgery pleurodesis that can be performed as well. And I don't even think you have to know that, but yeah. And then right here at the bottom, I think this is just more about thoracentesis. So one thing they should avoid coughing during the procedure, and then after they can go for it because you want to prevent atelectasis. In terms of complications, you definitely want to be monitoring their vital signs and their SpO2 always. So let's see here. So I think it says the need for the procedure to be discontinued, the output, oh wait, no, sorry. The output from the site of the thoracentesis should be monitored because excess drainage, more than 500 mLs, may cause hypotension. So if they're having excess, like more than 500 mLs in output, that can lead to hypotension. So it should be monitored. Like, are they having any shortness of breath as well, as we're removing the fluid or air from that space? And then they're also needing to be reassessed for their lung sounds and their vital signs for like a pneumothorax, because again, they can develop a pneumothorax, and then a chest x-ray should also be obtained because of the high risk of pneumothorax, and they should be developed to, or they should be encouraged to turn, cough, and deep breathe following the procedure. And like what I said earlier, following the procedure, a dry sterile dressing is typically applied to the site, and then a minimal amount of blood noted on the dressing is normal. So that's the only things with those that I would note. But yeah, I'll send you guys all of those like little notes that I have in between that. So now for the cardiac study guide, I'm not going to go through all this information. Afterload is just the pressure that the heart has to overcome. Preload is the amount of blood filling the heart before it contracts. And then all that stuff. Try to just go over that. Okay. So infective endocarditis, this is an infection. So again, we're talking about itis, inflammation. This I feel like is always associated with some type of infection. So infection of the innermost layer of the heart. So that's like the picture of what's going on there. And so you can see what's happening for that inflammation, and then the heart lining, and then the heart valve lining. So we're not having those proper blood flow or anything. So usually this can be caused through different types of things, either congenital genetics, and then abuses of drugs, things that they're doing that are causing these things to happen. And really a big one that they note is dental procedures and poor dental health. For complications, we're worried about heart failure, obviously, because we're having infection of the heart, and now we're having inflammation, and that can lead not only to like sepsis or like a systemic infection, but your heart's not being able to pump, so your heart is overworking. So eventually it can lead to like heart failure or chronic heart failure as well. So embolic complications of vegetation. So what that is in infective endocarditis, you're gonna have small clumps of bacteria, fibrin, platelets, and other debris or wastes, and this is what's known as vegetation, right? So vegetation is those small clumps of those little components. So this can form on the heart valves. So that's where you see it right there. That's the clumps right there. So that's the vegetation. They form on the heart valves or on the endocardium, which is the inner lining of the heart. So again, we saw it on the picture that was on the heart valve. So basically, they're susceptible to breaking off and embolizing, so they're able to travel to other parts of the body. So not only can they clot up of what's happening, oops, sorry about that. So not only is it cutting off the blood flow, what's going on between that atrium and that ventricle, but also what's happening is that it can embolize just like a regular clot, and then it can move to other different vessels and cause even more blockages as well. And when these emboli lodge into smaller blood vessels, they cause blockages, and that's why you see the Janeway's lesions with that. So Janeway's lesions are more associated with the emboli and those vegetation things, whereas with the Osler's nodes, they're actually more related to, I think it's called immune complex something breakdown, I think. Immune complex breakdown, I think that's what it was. Or basically, you don't need to know that, but what it is, it's basically an immune response where your antibodies are going to have to be made from this infection state. And as a result, these antibodies basically travel through the vessels, and then you're having inflammation of the vessels. So it's specifically vasculitis, so vessel inflammation. So those small vessels are going to be affected, and that's why with Osler's nodes, it's more related to like the immune response and the breakdown of what's happening with the antibodies. And that's why it's usually located in your fingers and toes, because it's going down to the big vessels. So vasculitis meaning inflammation of the vessels, but it's going down even to your smaller vessels as well. Whereas with the Janeway's lesions, those ones are talking about the actual vegetation. So you're literally cutting off blockages from the vegetation. So that's why it's more located in the palms or the soles. So it's kind of going to be bigger regions because it's going to be emboli, where it's going to be bigger and you're cutting off the blood flow to the entire region. Whereas with, again, the Osler's nose, it's super small, but that's more immune response related, but small. So that's why you're seeing the fingers or the toes for that. So hopefully that can help to kind of understand the differences. So that's why Janeways, it's going to be those bigger palms and soles, like your feet, things like that, because it's more related to the vegetation where it's literally cutting off the blood flow to that. So yeah, that's the only thing to note really with this. So manifestations, petechiae, and splinter hemorrhages. So just obviously with the blockages that you're seeing with that, and then with bruising, that's another thing to note. But Osler's nose and Janeway's lesions, they will ask you about this most likely. So Osler's is painful, tender, raised lesions that are small and red or purple. Whereas with Janeway's, they're painless, they're non-tender, and they're described as erythemia or hemorrhagic macules or papules that are typically small and flat. So what I would just know about this is the way that I kind of remembered it was like, oh, pain, like when you bump into something and you're in a pain, you're like, oh, that hurt. So that's kind of how I remembered it, but it is just kind of like memorizing these. So you would think that like because the vegetation is cutting off the palms, cutting off the blood flow, like it wouldn't hurt. But for this, it or would hurt, but for this, it's not gonna hurt. It's not gonna be tender. And also because they're small and flat, I would think about it like because they're small and flat, they're not necessarily as tender or painful. Because obviously, if you're having like, or let's say like even if you have a pimple, right? Sometimes like some pimples, like when they're big, like they can really hurt. They're really tender. So I would just think about it's like the same way with lesions. Like if they're smaller, they're not really going to hurt as much. And then Jane isn't in pain. So that's another thing you can remember. Jane is not in pain. But yeah, so you're going to do positive blood cultures and then an echo because obviously you're affecting the heart and the heart function of what's going on when you're having heart failure and can lead to heart failure. That's something we're worried about. And then obviously the blood cultures dealing with the infection state that's going on. And then also blood cultures can let you know if you're having a systemic infection as well. And then again, antibiotics, especially before their dental procedures, is what's happening with that. And again, I think the dental procedures, it has to relate to the vegetation states and all of those small clumps, but I could be wrong. But yeah, just make sure you know that with dental procedures, they just got dental work done or something. Okay, infective endocarditis or whatever is going to be the option for that. So valvular disease, I hated this because I feel like also I'm gonna be honest, Harding didn't ask us anything about this on the exam, and I remember being so mad because I had to like memorize it. Really, the one thing, rheumatic heart disease is literally the number one cause, and basically it's mostly associated with aortic valve. So aortic stenosis is usually going to be the most common thing you're going to see. But basically stenosis means narrowing, right? So valves become stiff. Those leaflets of those valves stick together. So it cannot open fully. So, or the valves may be fully open. But basically, we just associated that most likely they are not open. And that's usually what we're referring to. So it's not open. So you're having that blood flow literally just stay in there. In terms of regurgitation, the valve is incompetent or insufficient, so the leaflets do not close completely, which causes the blood to backflow. So I would just think about like GERD when you're having that backflow that's going on. So that pyloric like valve or whatever, all of those valves there, it's coming back up. So all the acid's coming back up and you can feel it. So that's the same exact thing with regurgitation, but just in the heart, in the valves. And that blood isn't able to go from the ventricle to the atrium or to like the aorta back to the left ventricle. So it's literally coming back. Like it's able to go, but it's not able to come back, or it's coming back is the problem. So what I would know for this, we're kind of talking about the left side of the heart because we're talking about aortic valve and then the mitral valve, right? So mitral being in between the atrium and the ventricle of the left side, and the aortic valve we're talking about between that left ventricle going to the aorta, right, and to the rest of the body. So the aortic valve is in between that. So that's what we're talking about. So with aortic stenosis, this is basically the blood flow is not going to the rest of the body because the aortic valve is just closed, right? So it's just staying in that left ventricle and not going anywhere. Again, with all of these, the causes are going to be usually related to rheumatic disease or fever. And then the murmurs for this is probably the only thing you have to know. I'm not going to really go over this just because I feel like I don't necessarily think she's going to test you over like, oh, fatigue, angina, like syncope. Like I don't necessarily think she asked that. I could be wrong. But I'll take a look because I tried to write down some of the stuff she would have on the exam. But I feel like she didn't ask about these, so I was kind of like, what's going on? But Yeah, we'll talk about this systolic and diastolic murmurs in a second. I'll try my best, but I find it I do get this confused a lot. But aortic regurgitation, basically this is blood flow to the left ventricle. So it's coming back from the aorta to the aortic valve back to the left ventricle because it's again regurgitating back. So that's why you have a widening pulse pressure. And then again, we're talking about diastolic murmur for that. For mitral stenosis, we're talking about again in between the left atrium and the left ventricle. So it's closed off, it's narrowed. So that atrium is just sticking with that blood there. And then you're going to see diastolic murmurs with that. And then with mitral regurgitation and with prolapse, the prolapse is related to the mitral regurgitation as well. So that's why I don't think I'm going to go over that, but it is related to that. So mitral regurgitation, again, the blood flow is coming back from the left ventricle into that left atrium as well. And then that's during systolic murmur. And then mitral valve prolapse kind of is related to mitral regurgitation because the leaflets are bulging into the left atrium. And this can be caused through fluid volume overload, or again, like genetics and something you're just born with. So you're gonna see systolic murmurs with that, but we'll talk about that in a second. Let me go to it. So I'm gonna send you guys this. I basically had to get it broken down because I always forget like what's happening. But basically with aortic stenosis, you're hearing a systolic murmur with that. And so the reason why is because the aortic valve is closed, right? Or narrowed. So there is an increased resistance to blood flow from the left ventricle into the aorta. So again, we're talking about the left side of the heart. We're talking about the aorta. The aortic valve is not able to have that lung, to be able to have that blood go from the left ventricle into that aorta to the rest of the body, right? So during systole, we're talking about during a contraction when the heart is contracting. So it's just stuck in the heart. So usually when the heart is contracting, that blood flow should be able to come to the ventricle, to the aorta, to the rest of the body, right? But in this case, that's not happening, but that's why you're hearing a systolic murmur, because again, it's trying to work to be able to have that blood flow go from that left ventricle to the rest of the body. Because it's closed off, that's not what's happening. So that's why you hear systolic murmur with that, because it's trying to contract to get rid of that. And that's what should be happening. But for aortic regurgitation, you're hearing diastolic murmurs because in aortic regurgitation, the aortic valve does not close properly. So you're having that blood go back from the aorta to the left ventricle, and this is during diastole. So diastole is whenever the heart is relaxing, right? So that's when the heart is filling. So contraction, it's getting rid of that blood so it can keep going to the next place. Whereas with diastole, we're talking about the heart is filling up with that blood. So that's why, because it's going back, it's going to be filling up, and that's why you hear the diastolic murmur with that. So with mitral stenosis, you're going to hear, so this is in between the left atrium and the left ventricle, so you're going to hear a diastolic murmur. So in mitral stenosis, the mitral valve is again narrowed. This obstructs blood flow from the left atrium to the left ventricle during diastole. And so the reason how I would think about this is because the left ventricle is struggling to push the blood the left atrium is struggling to push the blood to the left ventricle. So it's sticking in there, nothing's happening, because again, we're talking about like the left atrium, the left ventricle, the valve is in between, it's narrowed, so we're struggling. So it's trying, but nothing's happening. So that blood is remaining filled. Because it's remaining filled, and that's what diastole is, that's why you're hearing that diastolic sound and that diastolic murmur, because it's still full of blood and it's not going to the next place. So then with mitral regurgitation, so this means that it's in the left ventricle, but it keeps going back up to the left atrium. You're going to hear a systolic murmur. And the reason why is because, again, it's not closing completely. So the blood flow is going back, but it also is some of it's still going forward. So it still is contracting. Like you're still having regurgitation of it coming out. And this is just how I think about it. Like you're still having the blood flow come out because it's contracting, right? The atrium is contracting. So the blood is able to go from the atrium to the ventricle. But the problem is that it's kind of going back. So that's why you hear a holosystolic or pansystolic murmur, and that really is just a continuous murmur throughout the contraction for that. So it is contracting because it is going back. So that's why you hear the systolic for that. Whereas with the diastolic for the stenosis, the blood is still filled. in the heart. So it should be contracting and it should be getting rid of this blood, but it's not. So that's why I would just think about it like diastolic, the blood is remaining there, so it's going to be diastolic. Whereas with mitral regurgitation, systolic, it is actually going through, but it's not, some of it's still going back. So you might just hear a continuous, but you are going to hear a systolic murmur because it is being pumped in between that, but it is going back. But that's kind of how I thought about it. Like, I think I would just think about it like diastole, you're feeling the blood. So the blood is going to be sticking there. So if it's sticking there, it's going to be diastole. Whereas if it's moving, if it's regurgitating, it's going back, but you could still have the systolic murmur because it is still going further, it is still contracting. It's basically the opposite. So I would just think about it like if you just remember two, you can remember also the opposite. So if you feel like you don't understand that, that's fine. It is very confusing. So I would just think about it as like, if you just know aortic stenosis is systolic, aortic regurgitation is diastolic, it's going to be the exact same opposite. So mitral stenosis would be diastolic, and then mitral regurgitation would be systolic. So if you have to memorize it that way, do that. But I just think about it in a way where it's like if I really had to think about it, like with aortic stenosis, it's staying in there. It is contracting, but we're having that issue going on, regurgitation, and then obviously with the mitral stuff you're having, I would just think about it like how I explained it. That's how I thought about it. But again, like even I, like when I'm explaining it, I'm like, it gets very confusing. So try to read about this. And then for the prolapse, it is associated with a systolic murmur, but technically it's more of that continuous murmur that I was talking about. So those words where it's, I don't even know how to say it, holostolic or pansystolic murmur is more associated with that. Okay. So I'm not going to really talk this. Again, I feel like she didn't talk about this on the exam, but periods of rest, pace activities throughout the day, diuretics, you can give them ACE inhibitors for their pearls, vasodilators, anticoagulants for clots or emboli, because if that blood's staying in there, it's going to be stagnant, and with stagnant blood, we can have clots. For vasodilators, we're just preventing the preload and afterload, so the resistance or the pressure of what the heart has to go through when it's contracting to be able to get it to the rest of the body, right? Because obviously if you're having regurgitation or stenosis, you're not able to get that blood flow to the rest of the body. And then preload as well. So with the surgery, again, I feel like she didn't talk about this, but basically reconstruction, you're just fixing what's going on. Like with the prolapse, let's fix the leaflets. An annuloplasty, it's basically what this is. So it's just basically getting a ring to resize the opening. You're going to put sutures around it to gather excess tissue, and it can be used for both. And then for valve replacement, it's actually getting them a new valve. And so it can be mechanical or biological. So a transcatheter aortic valve replacement for treatment of aortic stenosis for patients who can't tolerate the surgical replacement. But again, I feel like they're not going to ask you about this. And then considerations, but again, I don't think that they're going to ask you about that. For pericarditis, inflammation of the pericardial sac. So again, this is kind of talking about some type of infection, right? Because we're talking about itis. Occurs following MI, usually is going to be seen through this. And so really with the patho for this, the pericardium becomes inflamed. The complex inflammatory mediators are basically involving themselves, and then you're going to have immune responses and you're going to see structural changes. So that's why you end up seeing the inflammation through that. And so usually I would think about like, remember like with an infection, you're going to be having that inflammatory response. So that's why if you're having an inflammation of that sac, yeah, it's going to be inflamed after an infection. So with manifestations, pain in the supine, I would make sure you know this, pain in supine position, relieved by sitting or leaning forward, possible auscultation of friction rub, which can also be associated with what? We talked about it, right? With the pleural effusion or pleuritis. And so usually with pleuritis though, but you can definitely see pleuritic chest pain and then ECG changes as well. So with diagnostics, you can do lab tests, radiographical diagnostic tests, but you don't, like, again, like what's she gonna ask you about that? Really, I think it's just the manifestation. And then with treatment, you can give them NSAIDs because it will relieve after time. It's, again, having to do with an infection usually, or after an MI. So it's going to be inflamed. That's going to be the body's natural response to be able to combat what the issue was. But again, just give them anti-inflammatories and just make sure you know the side effects for NSAIDs, right? And then complications, it can lead to pericardial effusion, which I'll talk about in a second, because I think the thing with what makes this confusing is that they can all like be connected and lead to one another, right? So, but basically pericardial effusion is collection of fluid between the pericardial layers. So this can include pus, blood, serum, lymph, or all of it. It hurts cardiac function as well. It's tolerated better if it occurs over time. And then it can lead to a cardiac tamponade. So basically, this is a normal heart, the pericardium. Now you have a buildup of fluid around it. So I would just think about it like you can have pericarditis, then it can lead to pericardial effusion, then it leads to a cardiac tamponade, which is what we do not want. So I would just think about it in a way where with pericarditis, we're talking about inflammation of the pericardial sac because of what happened with an infection, or let's say with an MI. As a result, because of those inflammatory responses and mediators being activated and the immune response that's happening, you're going to have an increase of excess fluid, right? So that's why you can see the pericardial effusion with that, because all of those components want to be happening, right? And remember, with like an infection, you have like vasodilation, you have the capillary permeability. So even though that has to do with your vessels, with your heart, it can be the same thing. You can have increased capillary permeability, and not capillary permeability, but permeability between the layers of the pericardium. So what happens is that fluid is able to get in there into those pericardial layers because you have that increased permeability between that pericardium and those pericardial layers. So you're going to have the fluid come in because, again, with the pericarditis, you're having that infection after it, or you have an MI because of the inflammatory response. It basically wants more fluid. And I would think about it in a way too, where you're having with the pericarditis that friction rub, right? So it's like rubbing against it, it's inflamed. So you're having those chest pain, you're having that pericardial space be inflamed because it is the outer layer of the heart. So of course it's going to have excess fluid and try to be able to decrease that like friction of what's going on. And because of that, that can lead to too much fluid excess. And that's why you see pericardial layers. So it could be to try to combat the pericarditis and the friction that's going on, and make sure we're not having that. But then as a result, because again, like you never know with people's bodies if they're having like an infectious state. Some people get infections and some people lead to sepsis. So you can have an inflammation of your pericardial sac. Your body's going to try to fix it by maybe putting more inflammatory mediators, by putting more fluid out there. So you're having less friction. So you're able to have it better. But then that can lead to an excess of fluid. And then eventually a cardiac tamponade is you've led to so much fluid to the point where now your heart is compressed. So almost exactly like a pneumothorax where you're having the pleural space disorder. So you're having the pleural space, something's going on with there. If there's fluid buildup, air buildup, and as a result, your lung is collapsing because of the pressure changes. So it's the same thing with cardiac tamponade, but it's different. Obviously, you're talking about fluid in the pericardium, and then now it's compressing the heart. So it's not able to contract and relax and release that blood properly. So that is life-threatening. So there's fluid, usually blood, in the pericardial sac. So that can be penetrating chest trauma, blunt trauma after heart surgery, because you never know what if they poke something. And so overall, just know that this decreases your cardiac output because of the decreased venous return of what's happening. So because it's surrounded, your heart is surrounded by this fluid of what's going on, but now it's surrounded to where your heart is literally compressed. That venous return of what's happening at top where it's able to come back to the heart is decreased because, again, it's compressed. It's not able to have that proper pump and be able to have a proper heart rate and a proper stroke volume and be able to get that BP out and everything. So manifestations, you do need to know this. Pulsus paradoxus. It's a decrease in systolic BP during inspiration. So very, make sure you know what that is as well, because she might also just say it and be like, what is it? So just it's a decrease in systolic, not diastolic, right? Systolic blood pressure during inspiration, and then a decreased right atrial pressure as well. And then you're seeing JVD and then Beck's triad. So classic set of 3 signs and symptoms of the Beck's triad that you do need to know, which is hypotension, muffled heart sounds, and elevated venous pressure. And so keep in mind that this is fluid buildup, usually blood, maybe associated from the outside of that heart layer, which is the pericardium. So of course your heart is compressed, so you're not going to be able to hear the heart because it's compressed and now has so much fluid around it. And so it's like, how am I going to be able to hear it? And because of the blood pressure changes of what's going on, you're going to see the hypotension because you're having decreased cardiac output, decreased venous return, and then elevated venous pressure because it's trying to get that venous return and get that cardiac output higher, right? So you're going to see increased venous pressure, but at the same time, you actually have decreased cardiac output and everything, and venous return. But it's going to try to be increased and elevated as a result. So it's kind of like compensating from that. And then a fast scan, which you don't really have to know, and then a pericardiocentesis. So kind of like a thoracentesis, but specifically to the pericardium. So it removes as little as 15 to 20 to improve the cardiac output, so that we're having that proper perfusion, proper oxygenation for the body as well. So blood from the sac doesn't clot unless the heart has been penetrated. It's another thing to know. But really, pericardiocentesis is used for that. So now we're talking about heart failure. Really, the only things you have to know for this is the meds and the manifestations. So this is basically characterized by myocardial cell dysfunction, and this can happen throughout so many different things, right? So it's an inability of the heart to pump enough cardiac output to meet the demands of the body. So this can be in different stages, A to D, which each stage is progressively worse, kind of like with cancer, but they don't use letters. And then risks, CAD, hypertension, diabetes. So anything that has to do with the coronary arteries being affected, but even if anything that has to deal with like your heart, like overworking and having to try super hard. So manifestation. So you have the left side and the right side. So what I would note is that remember your A and P. At the end of the day, that's why sometimes I like to review A and P too, is because your left side of the heart, you're like, okay, the fluid comes back from / into the lungs. And so I understand how it can be confusing, but just think about it like this. So you have your left atrium, you have the mitral valve, you have your left ventricle, it goes to the aorta to the rest of the body, right? But you're having left-sided heart failure. So that's not what's happening. You're not having that contraction so it can go for that blood flow to go. So really what's happening is the fluid is going to go from your left ventricle. It's going to go to it's not going to go back up, but it's not happening. So you're going from your left ventricle, then back to the mitral, back to the atrium. And now you're going to what? It was from your lungs, right? The pulmonary veins. So those pulmonary veins are going to be next to the left atrium, and then you're having it to the lungs. So that's why you see lung problems, because with left-sided heart failure, it's not being able to go through that entire space. So if you have to write up like the blood flow kind of and see how that works out, just remember like we're talking about for the left side of the heart, we're talking about the lungs, like it goes from the lungs, the blood's going to be oxygenated and then it's going to come back. But either way, on the left side of the heart, it's going to fail. So it's not working. We're not having proper like fluid exchange or whatever's going on. And so it's going to go back to the lungs. So that's why you're seeing lung signs and symptoms. So you're seeing shortness of breath, you're seeing fatigue, you're seeing crackles, and then you're seeing an S3 gallop, which is related to specifically fluid overload and poor compliance. So what I would remember, if you can't remember it, left side is SFC plus S3 is how I remembered it. And then I would just remember that's on the left. And then on the right side, so again, it goes from the right side, the right atrium to the right ventricle to then the pulmonary arteries to then the lungs so it can get oxygenated. And you're like, okay, well, it would be the opposite, right? Because the right side is failing. So it's really going to go from the ventricle to the atrium to the rest of the body, because we know it comes from the rest of the body, then it comes to the right side of that atrium to the ventricle. So it's just the fluid is backing back up. So because again, we're talking about heart failure, the fluid is not being able to move on and go forward like it should be. So it's going back up. So that's why you see peripheral edema, because it's going back from that ventricle to the atrium to the rest of the heart, or not to the rest of the heart, to the rest of the body, because that's where it came before the right side. So just think about what comes before both of these sides of the heart. So that's where you're going to see edema, because we're talking about the rest of the bodies. You're going to see weight gain, obviously, with the edema. And then with anorexia, and I would just think about it, this is how I thought about it, there's fluid in the stomach, so you're having less appetite. So the acronym for that was PAW that I came up with. And so like it is somewhat of memorizing, but I think if you know the patho of what's going on with your ANP, it kind of makes sense, right? So just think about what's happening before the heart, or those sides of the heart, and that's why you're having a backup, because it's failing to move on. That's why you're having a backup of those things. So specifically with the slow onset manifestations, these are related to left-sided heart failure. So you're having an increase of shortness of breath, difficulty when breathing on exertion, awakening at night when breathless, And then rapid weight gain with pulmonary edema develops, loss of appetite. And so those are more associated with right side, and then fatigue. But with pulmonary edema, basically, you probably will be asked about this: frothy sputum tinged with blood, or pink frothy sputum. So pink frothy sputum tinged with blood, excessive sweating, pale skin, extreme shortness of breath, dyspnea, wheezing, anxiety, chest pain, rapid and irregular heartbeat. So really, the one big thing to note with that is just the pink frothy sputum. So treatments, medications. So lisinopril for afterload, ARBs, losartan for afterload, and then diuretics for preload. And then, okay, to explain that, afterload meaning the pressure that the heart has to overcome to pump this blood out, right? So obviously I would just think about it like, that those ACE inhibitors, that those ARBs reduce blood pressure. And then with diuretics, we're talking about for preload, because again, preload has to do with the volume of what's happening. So you can reduce the volume by excreting out all of that volume, right? Because diuretics get rid of your volume. So you reduce the volume, so that's why it's for preload. So then with beta blockers, like the OLALs, they are negative inotropics and negative conotropics, right? So they reduce myocardial contractility initially, so just know that. And then for cardiac glycosides, you have digoxin, which is a positive inotrope, which basically helps pump the heart. So it's gonna help with cardiac output specifically, and help with the contractions of that. One thing for diuretics, before I talk about digoxin toxicity, for your diuretics, what are the most ones that we use? Furosemide, right? For furosemide, what kind of diuretic is that? That's a loop diuretic, right? So you're going to be getting rid of potassium. So you're going to be looking at for hypokalemia. Whereas with like spironolactone, that's sparing diuretic, right? So it's going to spare potassium. So you're going to have hyperkalemia with that. With digoxin toxicity, that's another thing you want to worry about with these meds. With digoxin toxicity, make sure you're with these meds, make sure you're I'm like all over the place. Make sure that you know like the signs and symptoms and things associated. That's why I talked about the diuretics. But specifically with digoxin toxicity, you're wanting to look out with this, look out for this. So this includes loss of appetite, nausea, vomiting, cardiac dysrhythmias, and then visual disturbances. And so I think ATI, I don't think she'll ask you this, but I think ATI always notes it as like yellow, like halo things that you can see as well, but visual disturbances for sure. And so right here is kind of a picture of what we see as like the different stages of heart failure and then what they're going to do as well. But yeah. So make sure you know your meds, make sure you know the signs and symptoms for that. And then last but not least, cardiomyopathy. This is just basically, again, due to a long process of what happens over time when your heart is overworking, right? So this is a group of diseases that affects the heart muscle, leads to structural and functional abnormalities. The heart becomes weak and large, thick, so it's basically inflamed. And again, this can happen for a number of reasons, but really all you have to know is different types. And again, she didn't ask us about this, but make sure you know it. So hypertrophic, this is diastolic dysfunction with thickened left ventricular wall. So the left wall of the heart is usually it is thicker than the right side of the heart. So that's why sometimes with age-related changes, you can see left ventricular hypertrophy. And usually that's because it's so thick anyways. So it's just saying that that thick left wall is thicker. And so that's why now it has a hard time filling. Because remember, during diastole, we're talking about filling time. We're talking about when that blood is filling. So filling volume. So it's hard for that blood to be able to fully fill because of that, how thick that wall is. So that's what it's saying. And just know that is risk and death for athletes. So usually you mostly see that one in athletes. The way that I would think about it is athletes are hyper. In terms of dilated, now you're talking about systolic dysfunction. And so this is with enlargement of all cardiac members. So this is the most common type. And so I would just think about it like dilation, like that's usually like the most common type. It sounds like it would be because it's dilated, right? So it just means all cardiac members are enlarged. So with systolic dysfunction, this is the only one that's systolic. And the reason why is because just think about it in a way where if all of the cardiac members are enlarged, your heart's not going to be able to contract as well. And that's what we're talking about with systolic, right? Your heart's not going to be able to contract because everything's super big. Whereas with like the thickened left ventricular wall earlier, like we're just having a hard time filling that part up. And then with restrictive, it's also diastolic. So, which is funny because the only one that starts with a D is systolic. So that's also like sometimes I try to find patterns. But restrictive, it's basically diastolic dysfunction. So we're not able to fill up that entire blood or the entire ventricles with blood because you're having them be so rigid. Those walls are rigid. So all of that blood, it's not able to just like fill it up because they're so rigid and they're wanting to stay in place. So how are they able to go in there? So this is the least common type. And so I would just think about it like too, like it's restrictive. So only certain people are going to get this. So it's the least common. So diastolic meaning having a hard time filling, systolic meaning having a hard time contracting. If everything's inflamed, you're going to have a hard time contracting. So that's going to be the dilated one. It's the most common one because all cardiac members, all people can definitely see like having enlargement. Whereas hypertrophic, now it's just talking about specifically the left ventricular wall, hyper for athletes, and then also it's having a hard time filling it up because it's talking about ventricular wall, it's talking about it's so thick, so can't fill up, that's diastolic. Or and then the last one, restrictive, it's restrictive, so least commonly seen, and then additionally having a hard time filling up because again those ventricular walls are so rigid. And then diagnostics, echo is going to be the thing you're going to do for that because you're going to look at what your heart function is at. And then angina symptoms, chest pain, dizziness, indigestion, nausea, vomiting, sweating, palpitation, shortness of breath, and then unexplained fatigue. So that's everything with that, but I feel like those signs and symptoms are basically all associated with heart, like ischemia and damage, you know? So treatments, medications, pacemaker if they really need it, and then just review code blue stuff. If you feel a pulse, great. What do we have to do to follow up with that? There's no pulse, initiate your code blue first, then you can start your cardiopulmonary resuscitation. So you can start CPR after you initiate code blue. You can't just start CPR without hitting the code blue button and expect like people are going to be coming in. You know what I mean? So just make sure you're paying attention to stuff like that. And then just make sure you know your MI core measures because that's another thing she might ask. I feel like this is just straight up a little bit memorizing. So remember with antidysrhythmics, if they're having certain types of dysrhythmias, you can give them that medication. For fibrinolytic therapies, that's the place ones, right? We want to prevent or dissolve any clots. So remember, those ones dissolve clots, they don't prevent. That's what anticoagulants are. If they're going to get a stent, a cabbage, make sure you know those stuff. ASA, so aspirin, antiplatelet. And then O2 if they need it, nitroglycerin for vasodilation. And then see here, beta blockers, OLALs, they're a negative inotrope, so they decrease contractility. So that's the workload of the heart. And then it's also negative conotrope, which also decreases the heart rate as well. And then core measures, again, that's everything I just said. So just make sure if they need a cardiac rehab referral, which they will need, everybody, all hospitals have to follow these protocols. But yeah, other than that, I think that's pretty much it. And I think I just repeated this page on accident, but I think this video is probably super long, but thank you guys so much for watching. And if you're able to join, let me know if you need anything. And other than that, have a good one. And I will make the Kahoot for your guys' next exam and try to help you out. But yeah, thank you guys so much.